and otherwise. And really the proof in the pudding is this evening that we've got 2 doctors in London and 1 Rav in Israel who are speaking together at one event to rabbis, doctors, interested lay people around the world. So very grateful, first of all, to Dr. Elisha Kahan for sponsoring or organizing this event, and for the whole Torat Harefua group that he set up. It's a very helpful, first of all, WhatsApp group, a support platform for doctors and rabbis to come together and discuss medical halacha issues, for doctors to explain to rabbis some of the medical issues, and rabbis to explain to doctors some of the halachic issues, and for us all to collaborate together and better all of our understandings of these very difficult and very complex issues. So thank you to Alicia. Also thank you to Rabbi Finchas, who's joining, as I say, we know it's late in Israel. I'm going to introduce him more deeply a little bit later, but just to say welcome to you, welcome also to Wolff. I'm Martin Glasser. I'm a consultant geriatrician at the Royal Free, and I am going to discuss with you a little bit about frailty. So, can you see my slides, is I suppose the first thing. I really want to explain what frailty is and how it impacts on patients, and what geriatric medicine is all about, and how we manage patients with frailty, and how that can impact on halachic decisions that need to be made for frail patients. So, frailty is really the loss of what we call physiological reserve, or what the biologists of aging would call a loss of the hermetic space. And essentially, in simple terms, it's where there is a lack of spare capacity in the body. Like any good complex system, the body has been designed to have lots of spare capacity so that should anything untoward or unexpected happen, the body can deal with it. Now, unlike single organ diseases where there's one problem and the body is dealing with that, in frailty there are lots and lots of little problems affecting lots and lots of different organs, and each of those saps away a little at the spare capacity in the body, until you find that someone who's frail is living down here very close to this point of decompensation, where they will transition from being fully independent to being dependent. And the way I like to think about it is really, if you imagine someone's body is a big rock trying to roll down a hill, and you've got lots of spare capacity in your body propping that rock up at the top of a hill. In someone who's frail, it only takes something very minor to come along, a small infection, constipation, pain, and some of that spare capacity has to go and deal with the new issue. And when that spare capacity leaves, the rock that's at the top of the hill, that's the body's ability to function, starts to roll down the hill. And then it gets to the point where hopefully we've dealt with the problem that's come along and the spare capacity can go back to supporting the rock. But even when that does happen and the spare capacity comes back to supporting the rock, it may not be strong enough to push the rock all the way back to the top of the hill. So you may get part of the way back up the hill, but slightly lower. Sometimes you never even get any of the way back up the hill. And sometimes the rock's built up so much momentum in the time that it's been rolling down the hill that the spare capacity is unable to stop it rolling further down the hill. That's important because we know that people who are frail have increased risk of lots of adverse outcomes, including falls, disability, admissions to hospital, and death. If we look at various illness trajectories, obviously this isn't everyone with each of these illnesses, but if you look at the typical illness trajectory of someone with cancer, they go along, they're very well for a long period of time, and then they have a sudden, quite dramatic decrease in functioning, and they die relatively quickly. Someone with single organ dysfunction has an ongoing downward trajectory. They have exacerbations of their condition, but then return back after that exacerbation to the same trajectory they were on, until eventually one of the exacerbations takes them to below the basic level of bodily functioning, and they die. Someone who's frail really goes along very slowly downhill, having ups and downs until eventually the body just runs out of all spare capacity and they fade away. So how do we measure frailty, and how do we detect frailty? If you were in primary care, a GP, then you're probably more likely to be using an electronic frailty index. And this is where your computer software will look for the presence of 36 different deficits and will link all these deficits together and give you an index of how frail any individual is. And we can see that that's quite a good predictor of mortality. People who are fit are much less likely to die than those who are severely frail, and you can see that 50% of people who are classified as severely frail will be dead in about 3.5 years. In hospital, we don't actually use that model, partly because we don't have necessarily the access to the primary care notes to be able to find all those 36 domains, but we do have a different way of screening for frailty, and it's actually also, you'll see, just as valid as the electronic index. So this is the clinical frailty scale devised by Ken Rockwood and his group in Dalhousie University in Canada. And that rates people on a scale of 1 to 9. So the first thing that's important to say is, when someone comes into hospital, we rate them based on how they were 2 weeks before their admission. So if someone's been bedbound for 2 weeks with a pneumonia, for a week with pneumonia, we don't worry about that. That doesn't affect their frailty scale. It's how they were before this illness came along. And you can see level 1 is very fit. Now, most of us probably aren't level 1. This is the fittest people for their age. So most of us will probably be 2 or maybe 3, well and managing well. Vulnerable people who don't have any limitation on their abilities to do things that make them independent, but do find that they're slowed up or a bit tired. They're classified as scale 4 or vulnerable. And really 5 to 8 are the increasing frailties. So moderately frail means you might need a bit of help with shopping and heavy housework. That's mildly frail. Severely frail means that you're completely dependent, and very severely frail means that you are so running out of that physiological reserve in your body that it's likely that you will not recover from even a very minor illness, and your prognosis is very limited. I just mentioned 2 things about that as well. So first of all, we're going to ignore 9 at the moment. That's for people who are actually quite well and probably would score a 2 or 3, but they've got another condition such as a terminal cancer that means that they are going to die within 6 months. And the other thing to say is that it doesn't matter why you are dependent. It could be physical reasons, it could be cognitive reasons, but you score the same in terms of your frailty scale. So as I said, we've got similar evidence for frailty scales for mortality as we do for the frailty index. And so you can see that, again, at about the 3.5 month point, people who have a score of 6 or 7 will, 3.5 year point, sorry, people with 6 or 7 have a 50% survival. Similarly, people who are more frail will be more likely to end up having to live in a care home. So I practice geriatric medicine, and really that's very different from most other fields of medicine, because we're not dealing with a single organ and failure of that organ. We're dealing with someone who is frail, who has lots and lots of little things, and there's no one thing that we can try and make better that's going to reverse their frailty. So really the role of geriatric medicine is to try and optimize the health and well-being of people who are living with frailty. We want to give them the maximum independence we can possibly give them, but at the same time recognizing that sometimes they are going to need care and ensuring that they have access to the right care when they need it. We don't do that alone as doctors. We need a big multidisciplinary team to help us achieve that, including different types of therapists, dietitians, nurses, the GP, and perhaps most importantly of all, the patient themselves and their family. And that's good. And as I say, we want to maintain health and independence, but we come back to this graph and we see that people who are frail are nearing the end of their life, and that inevitably they will die at some stage. And so an important part of geriatric medicine is also planning for people's death and trying to make sure it's the best and most appropriate death for them, and that treatments that we're giving are likely to work and not ones that are likely to actually do more harm than good. So just very quickly to think about that, and think about, for instance, in terms of CPR, which is going to be discussed a bit later, what that involves and the legalities of it. But I just very quickly would say, in 2 studies last year that published, in one study, when CPR was done to patients with a frailty scale of 5 to 8, so i.e. someone who was even mildly frail, in one study, no one survived to discharge from hospital. In the other study, only one person survived to discharge to hospital. We know when people need to go to intensive care, if they have a frailty scale of 5 to 8, that somewhere between 40 and 50% of them will be dead within 30 days, that only about 45% of them will survive the admission to intensive care, and that within a year, about 60 to 62% of them will be dead. Now, most people, when you ask them, say they actually want to die in their own home, but unfortunately, or possibly fortunately, depending how you look at it, the majority of people in the UK now die in hospital. So we as geriatricians have lots of difficult decisions that we try and make in conjunction with patients, and when the patient doesn't have capacity with their relatives or their advocate, really. I just want to bring you 3 cases that I've dealt with recently. I'm not going to tell you what the outcome was. I'm not going to tell you what the English law was. I'm not going to tell you what the Halacha was. I'm just going to tell you the cases to just get you thinking about the difficulties that we face. These are all based on real cases. I've slightly changed some of the details so that no one will hopefully recognize who the individual is. First case is an 84-year-old man. He's got advanced dementia. He is bedbound. He doesn't verbalize. He doesn't recognize his own family. He can't feed himself. He's doubly incontinent. Even when the staff in his nursing home try to feed him, or his family members try to feed him, more often than not, what they put in his mouth dribbles out the side of his mouth. He was admitted to hospital, vomiting up blood. He was extremely unwell, very, very low blood pressure, extremely anemic. He also developed a pneumonia because some of the blood he'd vomited up ended up in his lungs, and he had extremely low oxygen levels. So we had a discussion with his family, and we agreed that he should be for active treatment to try and get him better, and that the treatments that we would offer would be antibiotics for pneumonia, medicine to try and reduce acid in the stomach and to hopefully therefore allow whatever was bleeding to stop bleeding. We'd give him blood transfusions, we'd give him fluids. The family agreed that doing an endoscopy, putting a telescope down his mouth to look into his stomach and to try and find where the bleeding was coming from, would be very distressing for him, and that it's quite likely that he would die during that procedure. And so they agreed that that shouldn't happen. They also agreed that going to intensive care, being intubated and connected to ventilators and all sorts of monitors would also be extremely distressing for him, and that they shouldn't do that. However, when it came to discussing CPR, they insisted that the halacha was that if someone dies as a cardiac arrest, they should have CPR. And however hard the medical team tried to explain to them that if we weren't going to do everything we could to stop him having a cardiac arrest, then treating him once he had the cardiac arrest was illogical. And also that if he did have CPR, and in the very, very unlikely event it was successful, he did recover and would be resuscitated, then he'd end up on intensive care in exactly the situation that the family said he wouldn't have wanted to be in anyway. So that was the first situation. At the other extreme, I saw recently a 96-year-old lady. She lives alone and she's actually fully compos mentis. She's quite well. She has a private carer she pays to do her shopping, to do some cleaning, to help her in and out of the bath. But apart from that, she was able to dress herself. She did light housework. She would prepare her own meals. She did crosswords. However, she said to me when I saw her in the ward round, I've really got no reason to live anymore. Her husband was dead. She had no children. The only relative she had left was a distant cousin who was also in his 90s. She said, help me die. And when I explained that I couldn't do anything to hasten her death, she said to me, essentially, I'm not going to take any medicines that are going to prolong my life. I just want to die as soon as possible. So that's the other extreme, really. And then finally, I'm not sure this will be something that will be covered later in the talk. This might be slightly beyond the halachot that Rabbi Finchas is going to give, but this is the case of a 64-year-old man. He's dependent on alcohol. He's got alcoholic liver disease because of that, has recurrent bleeds from his upper gastrointestinal tract, and he has lots and lots of falls and traumatic head injuries and has had a bleed on his brain on more than one occasion because of that. He was in hospital and he said he wanted to go back home and that he would continue drinking. Now, we weren't sure if he had what we call the capacity to make that decision. Was he able to understand the decision he was making? Was he allowed to make an unwise decision? So we asked a second opinion from one of our psychiatry colleagues who came and said, no, that the brain damage from the drinking and the head injuries was affecting this gentleman's ability to make decisions and to weigh up the risks and benefits, and that therefore he wasn't capacitous to make this decision. And therefore we legally have to make a best interest decision for him. But the question is, this is a gentleman who all his life he's been drinking. All he wants to do is drink. He's been on the ward for a month now. He had a very severe alcohol detoxification when he came in, but he's now detoxed. But still, all he does is ask the nurses, can I have a beer, please? And when they say no, he gets very, very abusive towards them. So yes, we could send him to a care home where he wouldn't be able to access any alcohol, and he would probably be at less risk of falling. And even if he did fall, he'd be found more quickly and therefore treated more quickly, and potentially therefore he would live longer. The question is that in his best interest if he's going to spend the entire time shouting at people and being abusive to people because he wants to drink alcohol? And as I said, I'm not going to give you any of the answers to what we actually did. This is just to get you thinking. So just want to very quickly summarize to say frailty is a lack of physiological reserve, a spare capacity in the body. It can lead to multiple adverse outcomes, including death, and that we as geriatricians therefore have to take very many very difficult decisions, and often there's no low risk solution. So thank you very much for that. And I'll just stop sharing, and then I'd like to now ask Dr. Yaakov de Wolff to speak. Yaakov is an acute physician at Northwick Park Hospital, a very busy Northwest London hospital, and he's going to discuss for us the legal aspects in English law of end-of-life decisions, CPR, and treatment escalation plans. I think I should also say that I'm very grateful to Twitter for allowing Yaakov to have a couple of hours off to come and join us on this webinar.
Excellent. Thank you very much, Dr. Glasser and Bishus Rabbonim and esteemed colleagues. I'm talking only really from the medical legal perspective. I'm not going to cover anything halachic. I'm thoroughly unqualified for dealing with any such thing. As Martin said, I'm an acute medicine consultant based in a rather busy hospital, so this kind of thing, unfortunately, is something I deal with rather often. So I'm going to start with some terminology, because sometimes people end up confusing one thing with another. So the word resuscitation without a modifier doesn't actually mean to bring someone back to life. Treatment that is referred to as resuscitation is specifically a treatment to correct a physiological disorder in someone who's acutely unwell. So that is, for example, the administration of intravenous fluids to someone is profoundly dehydrated is considered resuscitation. Similarly, the administration of oxygen or any such thing as someone who was breathless, those are resuscitation measures. But I think increasingly when we use the word resuscitation, we refer specifically to a process that's called cardiopulmonary resuscitation. And what CPR is a set of treatments bunched together in a protocol that is given to someone who is in cardiorespiratory arrest, someone whose heart has stopped beating and someone who has stopped breathing spontaneously. Now, CPR exists in a continuum. Bystander CPR, if someone collapses in the street and someone starts doing chest compressions and mouth to mouth, I wouldn't recommend giving mouth to mouth at the moment. That's called basic life support. That is basically trying to maintain a degree of treatment until the cavalry arrives in the form of the ambulance service or Hatzalah. Increasingly, there's something called compression-only CPR, where we don't give mouth-to-mouth breaths anymore, and it's probably just as good as doing breaths as well. Now, when an ambulance crew or Hatzalah arrives, they take it a step further. They connect devices to directly monitor the electrical activity in the heart. They're able to administer medications while basic life support continues in an attempt to actually reverse the cardiac arrest. Basic life support does not, as a rule, reverse cardiac arrest. But so in the UK, this process is called ALS or advanced life support. The Americans got that first, and they call it ACLS, advanced cardiac life support. But the principles are effectively the same. Now, I've put straight underneath some very specific, rather wild ways in which someone can be treated for cardiac arrest that is not really used in anywhere apart from in very specific situations. So in the middle of cardiac surgery, the surgeon might simply squeeze the heart a bit. Similarly, there's a system called cardiopulmonary bypass, again used in specialist centers, or extracorporeal membrane or oxygenation. None of this is standard care, although there have been studies where ECMO is used as on the street, particularly in Paris. There's been studies about this. Now, if if advanced life support is successful, then you end up in a state called ROSC, return of spontaneous circulation. That means that the body is starting to make some effort to do things by itself. That does not mean that this person is going to survive, but it means that the attempt to restore life can now move on to treating the post-cardiac arrest situation. The outcomes of this process are measured in studies. Most of the time, the way the success of CPR is measured is with regard to survival to discharge from hospital. If someone is resuscitated effectively, but then dies again in hospital, that is not considered successful CPR, really. Furthermore, and unfortunately this is really important, many people who have received CPR for cardiac arrest sustain neurological damage because of a lack of blood supply to the brain, which means that many people with that studies looking into the success of cardiac arrest also need to look at how well is this person who has survived, can they do anything for themselves, or are they highly dependent? Now, CPR has existed in some form since the 1960s, when American physicians started to combine chest compressions and defibrillation and emergency drugs into this protocol. This became ACLS in the mid-1970s. They started doing studies where they put defibrillators on ambulances, including in Northern Ireland. There was very early adoption there. More recently, we have found that the quicker people with cardiac arrest have access to a defibrillator, the higher chance they can be treated with defibrillation. Not everyone in cardiac arrest requires defibrillation, but those who do stand to benefit greatly. which is why many public buildings now have automated electrical defibrillators that can be used by members of the public, sometimes with advice from 999 call handlers. Now, over roughly the same time, we have seen the development of intensive care as a process by which to look after critically ill patients. Many, particularly the medical members of the audience, will have seen the photos from Copenhagen, where they first started mechanical ventilation for people as part of a polio epidemic. That was really considered the birth of critical care medicine as a specialty. And since then, more and more treatments have been added to the arsenal of what we can do for a critically ill patient. Now, what actually does happen during CPR, the doctors you can plug here is now, because hopefully you've been on your mandatory training. But the first step of assessing someone who seems to have, whose heart seems to stop beating, the first step is to assess the airway, to look at whether someone's actually got something to obstruct the flow of air into the lungs, make sure that's removed, and from then on, making sure the airway is supported and it's actually possible for air to enter and leave. If someone is not breathing, again, we're not talking about COVID, we're talking about, generally speaking, if someone is not breathing spontaneously, then this is where someone would ordinarily have either mouth-to-mouth breaths or alternatively in hospital and ambulances with the back valve mask. The next step, so you'll see this is an ABC kind of thing. The next step is circulation. If someone's heart is not beating, then it's possible to circulate blood through the body by compressing the chest about 100 times a minute by pressing on the sternum pretty firmly. So watch your own back while you do this. If there is a defibrillator around, then this is also the point where it might be possible to administer electrical shocks to get a abnormally beating heart to beat regularly again. And once a heart solid crew or an ambulance crew arrives, it's possible to give medication such as adrenaline, amiodarone, and what have you. To be able to give those medicines, it is important to get access to the bloodstream, ideally using intravenous cannulas, so sticking hollow needles in to introduce a plastic tube in a blood vessel. If that's not possible, then an ambulance crew will drill into a bone, usually of the leg, and it's possible to give medication and fluids into the bone, into the marrow of the bone that will then be absorbed into the bloodstream. In hospital, this will also, when a cannula is inserted, it will also mean that certain values can be measured on the blood gas machine. While CPR continues, this is already moving into the ALS process, the more advanced resuscitation. The team that administers CPR starts looking for things that can be treated. So that's remembered by staff in 4 H's and 4 T's. It's a list of conditions that can cause cardiac arrest and might be treatable to reverse cardiac arrest. Meanwhile, someone is pressing on the chest, someone is giving breaths with the mask into the airway. And every 2 minutes, this is stopped to see what is happening with the patient. What is the rhythm of the heartbeat? Is it normal? Is it abnormal? And is there a cardiac output? Is the heart actually beating sufficiently well to circulate blood through the body? If that is the case, then ROSC has happened. The heart is able to perfuse the body, to circulate blood sufficiently to now move on to the next step, to stabilize someone and get them to the safest place, which is usually a hospital. Now, this process can't continue indefinitely. So if someone does not respond to many cycles of cardiopulmonary resuscitation, the team leader, in consultation with the other members of the team, will need to decide, have we looked at all the reversible causes? Is there any chance that this person is going to succeed getting their heartbeat back, or are we basically doing something that is becoming fruitless? And eventually an effort will be abandoned if someone hasn't responded. Sometimes in a young patient, the team will carry on for up to an hour because successes have been reported. Moving on to the problem. CPR is considered life-saving in cardiac arrest, and this terminology is used very widely in CPR training, in media depictions, learn to give basic life support because you might save a life. And on a daily basis, many people are indeed saved by early CPR, early defibrillation. However, there is a flip side to this. In many cases, and unfortunately the majority, CPR will not work. But this risk, as Dr. Glasser already alluded to, is greatly increased by the presence of reduced physiological reserve from illness, from frailty without illness. So in many cases, it will just not be possible for the heart to be restarted and for the breathing to become spontaneous. In some people, CPR will briefly work. Great, the heart beats back, now what? But actually, very soon after, within a few minutes, 15, 20 minutes, the heartbeat weakens, cardiac arrest recurs. And the question is then, are we going to start again? How much longer are we going to try and get this person going again? Then, as I mentioned earlier, there is a group where CPR will be effective, where someone is then successfully treated on intensive care subsequently. But when the sedation is weaned off, it turns out they've actually sustained very severe neurological damage. And they cannot do anything independently, might not even be aware of their surroundings. It is possible for someone who is receiving CPR to be aware. This has been very poorly studied, but I've certainly seen someone trying to breathe while they were receiving CPR because just enough blood was flowing to the brainstem and to the breathing muscles for this person to be able to breathe. And that it is possible for someone to be aware that they're receiving CPR. In hospital, there's an additional consideration, which again has not been very well studied, but someone receiving CPR in hospital usually has got about 10 members of staff dealing with them for half an hour, up to an hour, sometimes longer. In that time, they're not able to look after other patients. Similarly, they might end up being traumatized, particularly if they are repeatedly expected to attend attempts at CPR that will ultimately not be successful and are very grim to participate in. Moving on to intensive care, because I've mentioned intensive care before, and someone who survives CPR almost invariably requires intensive care. In someone who's young and very fit, who becomes extremely ill, the decision to start intensive care is usually very easy. However, there are various considerations as to why intensive care might not be the right treatment for a person. First of all, someone who's got reduced reserves, and actually even someone who is fit, the moment you start the intensive care treatment, which is mechanical ventilation or renal replacement therapy, initially make things a bit worse. And there's certainly been numerous cases, and I've unfortunately been involved in them personally, where someone is put on a ventilator and the process of getting them on the ventilator actually causes a deterioration that then can lead to almost immediate death. Most people in intensive care require sedation, or what's called in the popular press induced coma. And then this is really the crux. The decision to start intensive care is not even the hardest one. It's a decision on what to do if someone just continues to deteriorate or potentially even worse, simply shows no improvement whatsoever. And they get stuck either on a ventilator or on a renal replacement machine or various continuously infused medications, which creates really massive dilemmas, not even halachically, but clinically, as to at what point does this decision need to be made whether to withdraw these treatments, which will very often lead to someone passing away. Now, talking before COVID, the majority of those admitted to intensive care medicine were considered candidates, will survive. They will leave the intensive care unit eventually. But quite a large percentage, some around 30 to 40%, will not survive intensive care. They will suffer deterioration or care is withdrawn at some point. But surviving intensive care treatment is not the end of the story at all. There's then someone still remains in hospital and requires a prolonged and difficult recovery. People are often very weak. People often are very delirious. They experience hallucinations and often a degree of PTSD. Now, very important to point out here, prioritization of resources, so we don't have enough machines or not enough beds, is not usually the main reason why someone is not offered intensive care. And even during the COVID pandemic, hospitals have worked very hard to try and get everyone who is a candidate for intensive care treatment to actually get it, even if that means opening extra intensive care units. So moving on to the legal angle. There's something really weird about CPR. Normally when you have a medical treatment, you sit down with the surgeon or with the specialist who performs that treatment and says, this is what we're going to do, these are the risks, these are the benefits, these are the alternatives. But CPR is one treatment that we don't normally go through a consent process for, because we assume that it's not going to happen. The GMC, in fact, recommends that we discuss CPR on admission to hospital in every patient, even if it is a barn door decision that this patient, of course, is going to get CPR. They're 22 and they've come in for knee surgery. Technically speaking, we should be discussing it. I know this doesn't happen in practice, but it's a recommendation from the GMC. Now, here's the flip side. If someone has decided they don't want CPR, which possibly Martin's patient will be a good one for, that is something that needs to be respected, provided they understand what this means. So if they say to a doctor, one of my friends had CPR and they ended up in a nursing home, and I just don't want to ever be like that. We have to listen to them, even if we believe that CPR will be indicated. Similarly, if someone's got a valid advance directive that says the same thing, that needs to be honored, and it would actually be against the law to give them CPR if they were to have cardiac arrest. Now, here's the gray area. Most commonly, it's the medical team that looks after someone in a hospital that needs to make a decision, or in the community, in fact, that needs to balance whether someone is a candidate or not for receiving cardiopulmonary resuscitation. Most of the time, in my experience, it is fairly straightforward. The majority of patients, it's quite clear from the outset whether someone is or is not likely to have a good outcome from receiving CPR. And in those who are likely to not have a good outcome, the clinical team is usually quite capable of saying this patient shouldn't be offered CPR. There are grey cases, which is the minority. In that case, the patient's wishes, current or previously stated to the members of the family, are highly relevant. What would this person have wanted? Would they have been willing to go through with something that might or might not be successful, and might leave them in a quite badly damaged state? Now, some people don't want to be involved in this discussion. However, there was a landmark legal case from about 6 years ago. This was Janet Tracy, a woman with lung cancer, was treated in Cambridge University hospitals, where the decision to not perform CPR because of her lung cancer was not properly communicated to her family initially, and then to her herself. And the bottom line from the High Court judgment was, this was a civil case in the High Court, was that there is a presumption that people will want to be involved in this discussion. Even if it's uncomfortable, it's not a fun thing to talk about for anyone. But that shouldn't stop us from discussing it, because ultimately, this is about patient autonomy. It does happen that you have that discussion with a patient and someone says, "Doctor, I don't agree. I know you've told me I'm really quite frail. I've got a number of conditions that make CPR very unlikely to be successful. I want to try. I want you to try." Then there's the question. Sometimes a medical team will turn around and say, on balance, there is a chance of benefit. We will honor your request. However, there are many situations where that's considered inappropriate, and the expectation from the CPR is considered unrealistic. Under those circumstances, the recommendation is a second opinion should be offered, which in practice is an independent clinician, but will generally be from the same healthcare organization. An external second opinion is usually not offered, but if a patient insists, then it will be up to them to organize it. Now, what I just mentioned is in a patient who has got mental capacity to discuss these things. However, a very large proportion of people acutely ill in hospital are unable for some reason or another to discuss this in person. Either they've got a chronic cognitive impairment, such as dementia, or alternatively, their acute illness has made them delirious and unable to discuss this in great detail. Now, again, from the Tracy versus Cambridge legal case, there is a legal requirement for the involvement of a legal proxy. So if someone's appointed someone else to deal with their affairs, or alternatively, those who are close to the patient, which is usually their relatives or sometimes a close friend. Fundamentally, the decision rests with the clinical team. And the GMC guidance actually actively discourages creating the impression that the decision rests with someone else. Because it's actually not fair to ask them, oh, would you like your grand to be resuscitated or not? That is exactly the wrong way to go about it. And unfortunately, I've seen the impact of that impression being created and people are then feeling they must demand what is ultimately futile treatment. Sometimes the next of kin can influence these grey cases where it is not certain whether someone is or is not going to benefit, and the patient's previous opinion matters. Now, it is possible that the disagreement is not resolved. You offer a second opinion, there is still lack of consensus between either the patient or their next of kin and the clinical team about what is and is not appropriate. And in the guidelines, there's a whole sequence of possible ways to resolve this further. So it might involve independent advocates. There's in mental capacity law, there's IMCAS, the independent mental capacity advocates. It might be possible to consult all the doctors, get a second or even a third opinion, to hold a case conference, actually sit everyone down in a room, or seek out a local mediation process. Now, as a very last resort, and this does happen, unfortunately, clinical decisions may be challenged in court, and that includes decisions about CPR. So the most recent celebrated causes that fit here will be the Alfie Gard and Charlie Gard and Alfie Evans, which is not actually about CPR, but withdrawal of critical care. But those are good examples where clinical decisions were challenged through the legal process, where ultimately it fell to a judge to decide which expert was going to have to be followed. There are two important caveats in the GMC guidelines that I'd like to emphasize. First of all, a DNA CPR decision only applies to CPR. It does not in any other way dictate what is appropriate treatment for this particular person. Historically, this has unfortunately been a major thing. This patient is not a candidate for CPR, therefore, they must also not have this out on the other. The flip side to that is the reason someone has a DNA CPR decision is usually related to their ability to survive a major stress to the body. That means that there are very often, even though there's not a direct link, there's an indirect link with CPR in the sense that someone is not going to also not likely to be able to survive, particularly intensive care treatments, major surgery, etc. But one should not directly influence the other. The GMC guideline makes another important emphasis, and that is DNA CPR does not mean that CPR should never be administered, because there are some niche situations where brief administration of basic life support or even ALS might be appropriate. And they give as an example someone who receives a general anesthetic and just at that point they respond very poorly to the induction of anesthesia, and there is very briefly a loss of cardiac output. So it is that there are situations where it needs to be deviated from. The famous form, here we go. The popular press talks about forms a lot. The form is actually only the output of a decision. A DNA CPR decision should be recorded meticulously and in detail, the content of the discussion with the patient, with the relatives, with the clinical team. And this all goes onto this form. The reason it's red is because it needs to be easy to find in emergencies, but it has also lent it a rather alarming shape and form. And this is something you see mentioned in the popular press very often. Now, in the last probably decade, there's been an increasing emphasis on broadening the decision process and the recording process into something much wider called the treatment escalation form, or the respect form, or the after form in Cambridge. This is not just about CPR, but it is about all kinds of emergencies. Because if you're discussing one, it's actually a really good idea to discuss everything else. And what this form does, it captures a lot of emergencies, intensive care treatment, emergency fluids, and any kind of other situations that might arise in hospital or even at home. And you might therefore come across situations where it's not just a DNA CPR form, but actually respect form is similar as well. And these are the main references in case anyone's interested. I'm going to stop there. Thank you.
Thank you very much, Jakob. That was very interesting, and I hope shed a lot of light on the process for the non-medical professionals who are here. We have probably got time for a couple of quick questions. There are a few in the chat, so I'll maybe just so there's one about, is it automatic for anyone who is frail to be therefore given a DNA CPR? And to that, I would probably one for me to answer, and the answer is that we know that the more frail you are, the more you progress up the scale of frailty, the less likely you are to survive CPR. And therefore, I'd say that certainly in this country, it would be pretty much expected that anyone whose frailty score is 6 or 7 or 8 would have DNA CPR. People who are 5, so are just mildly frail, that would probably be a slightly more grey area and might be more open to discussion. I think possibly out with the froom community, when I discuss this with patients who are at that level of frailty, very often they say, well, actually, as Jakob has described, it's unlikely that I will survive to leave hospital, and even if I do, I'll almost certainly have suffered more impairment, and my functional level will be considerably worse than it was when I started, and I don't want it. But I think for someone who has said I do want it, then that would be open to discussion and really might depend on the specific case. There was another question about how much is this a self-fulfilling prophecy, that if we don't resuscitate people, they're going to die. To answer that, I would just say that the figures I quoted about survival from CPR are people in whom CPR was offered. So we know that in the 2 studies, when CPR was offered to people who were even mildly frail, we only had 1 person who survived to leave hospital. So I think it is not just a self-fulfilling prophecy, it is a realistic expectation because of their physiology, I'm afraid. There was another question about fluids. I think maybe what we should do is hear about the Halacha aspect of things first, and then we can, if we have time, take more questions, and that might involve discussing the halachot of fluids at end of life, as well as the practicalities of fluids in an NHS hospital at the end of life. So without further ado, I will ask Rabbi Yehuda Finchas to speak. It's a real privilege to us to have Rabbi Finchas here. He's a big Talmid Chacham, an expert in the medical halacha, and he founded the Torat Habayit Medical Halacha Institute, where he fields questions from doctors, rabbis, lay people, and gives all of us the benefit of expertise, not only on that forum, but also on the Torat Harefuah WhatsApp group that really was the kick-started this event, and that we'll hopefully be hosting so many more. We know it's very late for you in Israel at the moment, so I shall, without further ado, ask you to start speaking. Thank you. I think you might be muted still.
Okay, thank you so much for your word of introduction, and to Dr. Wolff as well. Just to understand the medical complexities is really important, and adds a lot to the discussion, and it's so important. And I'd like to thank Dr. Alicia Khan as well for arranging and having this platform where rabbis and doctors can discuss these things together. I will be speaking from a halachic point of view, and I would like to start by quoting the words of Moshe Feinstein, where he talks about, and I'll be translating, I think it is important to see the text inside for accuracy, and also people who want to review this afterwards will be able to have that opportunity as well. And he speaks about that making decisions in end of life is so challenging, and it's such a responsibility that a lot of analysis has to go into it, because we're talking about pikuach nefesh, life and death. And he writes that we need to get all the Talmidei Chachamim together with expert doctors in order that we can have an answer. And this is something which we are doing and are trying to understand today. And I will only be quoting and using the very greatest of halachic authorities, if you like, the hierarchy of rabbinic rulings, the policymakers. Not everyone in such a difficult and complex subject, can be considered an authority, and I will be bringing them accurately and in a balanced way, because I think it is important to understand, definitely in general terms, the different opinions that there are in halacha, and that way we'll be able to be sensitive to other people's opinions and differences, whether we agree with them or not. And I think it's fair to say that this won't be halacha lema'aseh, because there are a lot of complexities, and there are gray areas, and there are issues which there'll be exceptions to the rule as well. But at the end of the day, these are questions which people are not able to sleep at night because of whether it's the patient, whether it's the families, the doctors. And very often these questions come up many years later. Very often people come up to me and will tell me, Rabbi, I heard your talk, and I want to know, my father, my mother was in this situation, and it could be sometimes 15, 20 years prior, and I wanted to know, did I make the right decision? And even doctors, they come up and they ask me, and they'll tell me, listen, when I was a doctor, I did this, I did that. And so these are things which people, live with for many, many years, very complex decisions, and they need to be discussed. So before I get into the halacha, it is important to realize it's not only a halachic issue. Around the world, different, here we can see that to withhold or withdraw treatment vary considerably depending on many. I can't actually read it because it's of different practice, culture, and religion. So there are different ways of understanding it even before we come to the halacha. The default position, however, is in favor of prolonging life in general, and in the GMC, which is like a UK code for doctors, it writes that quite clearly, that the presumption would be in favor of prolonging life. That is the default position. However, where they do have the right to refuse, and even if it seems irrational to a doctor, and this is the issue which Dr. Wolff spoke before, that there would be areas where the doctor would feel that it's not appropriate, and that they should be explained the reasons, and be given a second opinion or access to legal representation. This is quite unique to the United Kingdom. So for example, in Israel, for example, and this is actually brought from the Knesset law of brain death, something very interesting, that even if somebody who's brain dead and legally they give the death certificate once they've been diagnosed as brain dead. However, if the family do not want them to be taken off the respirator, then that would be the law. So things are very different. And this is something which I realized when I started lecturing in the United States, that they have something called LTACH, which is a long-term acute care hospitals, where once the patient had been stabilized in an ICU or ITU unit, then they would be moved to there, where they allocate a lot of resources to prolong life, and sometimes even in hospital wards. That definitely happens in Israel, even for long-term ventilated patients. And it's very interesting speaking to doctors who have worked in different countries, their different experiences. And it's important to note nothing to do with a person's religious observance. And I will be speaking about that shortly as well. So it's not only in Halacha where we do find difference of opinions. In another paper called the Joint Statement as well, it talks about non-discrimination, and we can't assume that, you know, even the same decision would apply to people in the same condition. Decisions must not be made on the basis of assumptions based solely on factors such as the person's age, disability, or the professional subjective view of a person's quality of life. It shouldn't be blanket policies for CPR or not CPR, whether it's for all patients in a hospice, nursing homes, below a certain age, might be unethical and probably unlawful. So this is very important that we do definitely in Judaism, we look at it in a case-by-case analysis. Now, the best place to start is the Gemara in Yuma, and I'll translate. It's talking about a situation where a building collapsed on somebody on Shabbat. The person was crushed under the building, and the Gemara says, Matzau Chai, if they found him alive, then they have to continue trying to save this person's life. So the Gemara asks, oh, that's obvious if he's alive. And here the Gemara answers something very interesting. What this means is that even if a person only live a very short while, in that situation, they should still continue with the efforts to try and save this person's life, even on Shabbat. And this, by the way, is a famous Gemara, which is used also for in the brain death debate, when is a person considered dead or not, which I won't be discussing today. Now, what is interesting is that this halacha is brought in the Shulchan Aruch, and the Biur Halacha, which is another commentary by the Mishnah Brura, the Chofetz Chaim, he writes something very interesting. And this is one position which is held. And this is, we all know, this is the classical commentary on the Shulchan Aruch, and it's considered an authority in the world of Halacha. And he writes that one reason is that why do we try and save a person's life, even if it's going to be for a very short amount of time? Because it says, because maybe in that time, he'll be able to do vidui. However, he continued away, but that isn't a real answer, because whether they can continue doing and performing the mitzvot does not make any matter. And he talks about, I'm not going to read it all, just some main points. Even if a person is severely injured or disabled, that would be the same. And this is the main point here, which many rabbinic authorities quote. And you might, and I'll read it in Hebrew and then in English. If a doctor says that this medication or treatment would help him to extend his life even for a few moments, even if the vast majority of cases, it's not going to help, and it's only going to be for a short amount of time, then we still need to be Mechalel Shabbat for this person. And this, like I said, is by the Chofetz Chaim, and this is championed especially regarding end-of-life issues by Rabbi Eliezer Weldenberg, the Sitz Eliezer, who talks about that we do need to go and do as much as we can to save somebody's life, and he uses this Gemara and this Biur Halacha as a basis to that thought. Now, this, like I said before, is not only a halachic issue. Here is just, I copied and pasted an email in 2008, when I was in the States. I gave a lecture, and one of the doctors reached out to me, and he wrote to me. And there's quite an unanimous agreement. He's an intensivist. He works in a big ICU hospital in the United States. And he said that the unanimous agreement is that we should do this type. And the types of people that we have track record of putting on life support may shock you, such as end-stage cancer patients, end-stage heart failure patients, as well as low-functioning elderly. So we see clearly, and this, I'm not talking, this is not a Jewish hospital. Most of his patients aren't even Jewish, actually. And like I said, nothing to do with his religious or observing background. If I remember, I think he was very conservative. He said to me like this: if it's legal, then my patients have autonomy to refuse or to have the treatment which they want, just as long as there's a commitment. He said, I want a commitment from the patient or from their family that whatever they decide, that they will go through fully, they understand what they'll be going through. And when I asked him, and don't you think it might be futile? He said, that is the patient's decision. That's not mine. And it's not the insurance, because in the United States, and it might be different in the United Kingdom because it is the National Health Service, maybe things are done differently. But again, this is not necessarily a halachic issue. In this, I know many people might find difficult. However, on the other hand, we find some leading rabbinic figures. This is the Stipler of Rabbi Yaakov Yisrael and Kanievsky from Bnei Brak, where he speaks about the question. He says that it needs a lot of halachic analysis, but he says that in situations where a person has a very, what we call chayei sha'ah, which I will describe shortly, we have a rule of shev ta'aseh. You can leave the default position if a person is suffering and he didn't find a reason why that you have to forcefully prolong somebody's life and stop the dying process, when if you just let the person die, he didn't feel that was an issue. The same thing is with Shlomo Zalman Auerbach. He speaks about a gosses, and it is very important to see these texts inside, because sometimes people do misinterpret them by accident, or they don't fully understand them. Here he's actually talking about a gosses, and he writes that if this person is suffering from uncontrollable pain, then even though we still need to give him food and oxygen, however, if there are going to be certain medications which are just going to cause him pain, then we do not have to do that if the patient actually asks that he doesn't want to be treated in that way. But he also mentions, and many times that Rav Shlomo Zalman Auerbach is quoted, they do not mention the end part of the quote, that you should also give him a choice and explain to him that some people, that if they're able to live with that, with that state of suffering, there is also some spiritual benefit to that decision. However, at the end of the day, the decision lies with the patient. And Professor Avraham, in Nishmat Avraham, he gives 5 different points where withholding aggressive treatment would be okay. And we're only talking about withholding here. There's the difference between withdrawing and withholding treatment in Halacha, and today we'll only be talking about withholding because that would be considered Sheval Tafseh. I haven't actually actively done something. I've just passively let the dying process continue. But he talks about an incurable end-of-life illness. It's uncontrollable suffering because they're unable to regulate the pain. And any treatment will just prolong the life just for a short time and cause a lot of distress. Should be discussed with the qualified rabbi, and the patient has given his thoughts on the matter as well. And with Moshe Feinstein, he brings two main proofs to this idea. Number one is from the Gemara in Ketubot, where it talks about Rebbe. Rebbe was the author of the Mishnah, and he was seriously ill. He was suffering a lot, and at the time, all the rabbis stopped and they began praying. Things did not change for the better. He was still suffering, and his housekeeper started to pray that he should die. And the Feinstein writes that since this Gemara is, and this is what happened at the end of the day, this would be a proof that if doctors see that there is actually no cure and a person is suffering uncontrollably and there's no way of dealing with that pain, then you do not have to give therapy, medication. You can leave, and like I said before, because at the end of the day, by not doing anything, by leaving him passively to die would be okay, as long as it's not actively causing him to die any earlier. But he talks about also pain should be regulated in a way that it won't kill him, but the balance has to be done. However, even with this approach, there are quite a few exclusions to the rule as well, and conditions. So for example, he says that oxygen should still be given even if he can't actually be healed. And he brings another he brings another quote from the Shulchan Aruch where it talks about that if somebody is dying and you shouldn't stop the neshama from leaving the body. And he explains the reason is because that is causing pain. And when pain is involved, we are allowed to let the natural dying process to continue. But again, his rationale is because the person is in pain. But when he talks about, and all these quotes are in the same volume of the Igrot Moshe, this is his classical response. He talks about that if someone is a trefa, that's somebody who's seriously ill, who probably won't have more than 12 months of living, then the doctors are still obligated to take away the pain and try and extend his life as much as possible. So we see this again and again in many situations. Here he's talking about somebody who is a cancer patient and there is no therapy, and again, there's no way to even cure him, and all we're doing is extending his life, which is painful. We have to let the patient know, and we ask him, what does he want to do? And we give him a choice. If you can contain that suffering and you want to take the medication, then fine, you can do that. But if you do not want to do that, then he says that you don't have to needlessly prolong life in such a situation when the pain cannot be regulated. And this is very, very important. We see this over and over again. I want to bring another example again from, he talks about a terminally ill patient who's not expected to live actually more than a week, a few days, and then he suddenly gets pneumonia. And he asked him, what do we do in such a situation? And he writes, well, I don't see absolutely any reason why we shouldn't treat the second illness, the pneumonia. And this is talking about somebody who's living only for 1 week. And he writes, I do not know any reason to even doubt this unless we're going to be causing him damage by giving that treatment as well. So we see this quite clearly from the response of the Moshe Feinstein, that it is the uncontrollable pain, which allows us, in somebody who's any case dying, that we can just allow the dying process to continue. Similarly, he talks about a PVS patient as well. Should they be treated? And he talks about somebody who's in a serious accident. And he writes, I don't see any reason why you should think it's going to be any different. But definitely, this is something simple and clear that you still need to do whatever you can. And it makes no difference to his mental capacity at that moment. Again, it's something we're talking about somebody who's not actually suffering. And even more, and again, there's so many of these. And what I do find, which is a bit unfortunate, is that sometimes they do quote Feinstein, but they don't bring all the different sources, and there are quite a few which you can just read for yourselves, all in the same volume, one after another. He's talking about an elderly person who became ill, and he says that the doctors still have the obligation, just like a younger patient. And he says, and this is talking about where he's not suffering. Because if he was, then we would, like we said before, an incurable illness, somebody suffering, we can let the dying process just follow through. And even if the doctor said, even if the patient says, I've had enough, he says that we shouldn't even entertain such ideas because it is treatable and the person is not in actual pain. So this is very clear from the works of the Feinstein, the works of the Shlomo Zalman Auerbach and the Stipler. And even though they are different to the Sitz Eliezer of Braunenberg, which I quoted before, however, it is important to realize that they're talking when they're set conditions where, number one, it's incurable disease. Number two, it's what we call Chaye Sha'ah, and that's why I wrote here, it's an accurate diagnosis and prognosis. And sometimes this is very difficult, and this is what the doctors were speaking about before. Sometimes it is not possible to really know and put your finger, how long is Chaye Sha'ah? Even in halachic response, there's a difference of opinion between whether it's 6 months, whether it's 12 months. Obviously, if somebody has a chronic condition, end-of-life illness, end-stage cancer, ALS, whatever the situation might be, it's going to be much easier to give a prognosis, and you can tell the body is starting to shut down. There's nothing really much that can be done apart from palliative care. In those situations, then those set of poskim would allow just the Sheba al Tase approach, the default approach, but we have to understand, are they in pain? Can they be controlled? And what will happen if you do nothing? What are the risks there? And like we said before, what are the person's wishes? So it's not just a question of CPR or not CPR, even going into an ICU unit, because it's much more complex than that. Sometimes it might be a question of just giving antibiotics or presses, dialysis. I had a case recently of a doctor from New York that was discussing with me a case. He works in NYU, one of the considered one of the top 10 hospitals in the United States. And at the beginning of COVID, an elderly man, his kidneys weren't functioning. Family wanted to do whatever they could to help their father. They fought with the hospital to put him in dialysis. He needed a couple of presses, antibiotics. He needed to be ventilated as well. And in the end, and the doctors didn't give any assurances, they didn't give any guarantees, but they managed to wean him off the presses and eventually even the dialysis, because the kidneys started to regain function. Even the ventilator, they managed to wean him off. And at the end of the day, I asked the doctor, wow, that's amazing. He said, listen, this doesn't happen often, but at the end of the day, this is why we have aggressive treatment. It's for these difficult cases. And if the patient is willing to go through that, and that is his wishes, then I don't have any issue by providing them for him. It's done with his consent, the family are willing to do it. And it's just a different way of looking at the situation. And again, very often it's nothing to do with Halacha or being Jewish or not, because many, and I find this a lot, like I said, on my travels, especially to the United States, that their kind of mindset is different, and they will let the patient decide. They will give him all the information and they'll tell them, like the doctors correctly said here, that it might not work and its survival to discharge might be very small, and we don't know if there's going to be any neurological damage or how you're going to cope or function or for how long. But once they do know that, and they've been given a choice, again, in England, that might not happen because their hands have tied. The doctors might not, hospital policy might not allow it. They might feel that's viewed out. I mean, okay, there's nothing you can do. That's the way it is. They do not allocate these resources and treatment and the care, which is after the ICU, which is also important. And if that's the case, there's nothing you can do. But and this is also important to realize, because sometimes people from the United Kingdom might ask a rabbi from America or Israel or even doctors, and they will get a different answer also because of the different approaches in the different health systems. And that is something important to realize as well. And the doctor can say, listen, I understand, I'm sensitive to your wishes, but at the end of the day, in this situation, we're not going to, it's not going to, I can't do this by myself. We need the hospital. This is policy. Unfortunately, there's nothing much I can do. But at the end of the day, I do think that it should be the patient's decision. And if we have a look here, and this is again another quote of the Feinstein, which isn't quoted very often, but it's found very, very interesting, where he writes again, that if we're talking about an illness where the doctors say there's absolutely no cure and there's no way of controlling the pain, we do not have to hold and prolong the life of a person who is suffering in such a situation, and we can let the natural course of dying continue. But he adds, you should also be a little bit suspicious, and you should ask as many doctors as possible and get a second opinion, even junior doctors. He feels sometimes they might have an idea which other doctors don't. I don't know if that's going to work practically, but somebody did send me a paper written by a rabbi doctor recently where he spoke, and I was a bit shocked where he said, you have to make sure you get all the accurate information. Nothing is distorted in any way, because it's only on that basis that you'll be able to give a final halakhic answer. Like I mentioned before, this does not apply to oxygen. Both Reb Shlomo Zalman Auerbach and Reb Feinstein says that, oxygen still needs to be given. It doesn't always have to be invasive. If it could be a non-invasive way of giving oxygen, very often that might be a appropriate. And hydration and nutrition. So Maimonides here talks about that, and this is, I know, is a very, very, if you want to call it controversial topic, at least for some people, where they feel that, you should just let the natural course of death continue, even when it's regarding hydration, nutrition. And one of the questions which was given before was somebody who's, is there much pain? What's the benefit? But it's quite clear also with Moshe Feinstein, and he writes clearly, you can't compare this. He writes this in a few places, I didn't quote them all, that we cannot compare medical treatment to providing nutrition and hydration. But I did hear a very big rabbi recently in a class which he gave, but he says, no, but Moshe doesn't really make a distinction between them. And it is clear, and not only does he make a distinction, he explains why there is a distinction, because these are things which are, expected and not considered aggressive unless they cause damage. And the same thing is by Reb Shlomo Zalman Auerbach, again quoted in Menishmat Avraham by Professor Avraham, where he talks about there's going to be differences between aggressive treatments and non-aggressive treatments. And definitely you won't apply to giving oxygen or nutrition by any way, even by if you need to give a PEG or obviously nasogastric would be easier, but if necessary, a PEG would be mandated. And I did see in the GMC that they do consider that nutrition and hydration as a medical treatment. And I also saw in the death certificate that if they actually withdraw what we call clinical artificial nutrition and hydration of somebody who suffers from someone who's unconscious, but in the death certificate, the original brain injury should be given as primary cause of death, but not the actual dying because of lack of hydration and nutrition. And we find something very interesting, because I am asked this. I was actually in the United States. I was invited to a community which had many, many doctors. It was a very affluent community. It was a seaside resort. It was during the summer holidays. And one of the many doctors there, and one of the participants asked, he said, I have a father who has mild, moderate Alzheimer's, and he can't swallow. And the doctor said, listen, you've got a choice. Either we're going to just regulate the pain, but he'll probably die in a couple of weeks. Oh, we have to do a PEG. And he said, Rabbi, what's your opinion? So I was trying to think, but I didn't. And he shouted, Rabbi, why are you hesitating? A bit shocked. He said, we gave the okay that he should have the PEG. We knew there was a certain risk, but we gave okay. Why are you hesitating? And I spoke to this person afterwards, and every time I go back to that community, we speak, and his father passed away last year. But it was something which really had, and again, this person was not particularly religious whatsoever. And the Gemara in Avodah Zarah speaks about a similar situation. This is the classical Gemara which talks about how much risk can you do in order to save your life if you have a dangerous disease, which in any case is going to kill you. I'm not going to go and discuss the whole context of the situation, but it talks about the case of the 4 lepers who were outside of the city boundaries. They had no food. They felt they were dying of starvation. If they didn't do something soon, they needed to eat. The city next to them was an enemy city where they were having a fight against, but they had no choice. And they decided to go. They knew that if they would have been caught by the soldiers, they would have been killed immediately. But they knew if they didn't go and try and seek some food, they were going to die shortly afterwards in any case. And there the Halacha says that they were allowed to do such a thing, because since they were going to die in any case, there was no problem for them to risk their lives in order to attain food as well. And so I definitely think that when we have a question of having a PEG or having artificial nutrition or hydration, even if there is a risk, again, I'm not talking about, even if it's, and I don't think the risk is so high, it's definitely not up to 50% risk of dying from the actual procedure, but if the risk is low, it definitely would be allowed, according to Halacha, to have that procedure done, as we see clearly from the Gemara. And I found in the Cochrane database, which is very important, and for those who aren't doctors who are watching this, this is where they do systematic reviews and to try to assess, because different research papers might have different conclusions, and some of them might not be, written in such a great fashion, or they might have a bias, or they might have a small pool of people. And so they try and look at all the different reviews on a specific subject, and then they come to a systematic analysis using many different research papers. And the doctors can, access this very easily, but this is something which many doctors do talk to me about. Medically assisted hydration for adult palliative care patients. And in the actual conclusion, there are only 6 studies looking into this. And there are insufficient good quality studies to make any definitive recommendations. As a result, it is not possible to define the benefits and the harms of this treatment clearly. And I think that is something also important to understand, because we normally hear it's harmful. Again, it's not a treatment where they're going to recover from their illness. But the question is, what are the harms? What are the benefits? And it seems from here that there are insufficient good quality studies to make a definitive recommendation. Regarding DNR, which was mentioned, definitely with end-case illnesses, end-stage illnesses, it definitely would be permitted to sign the DNR form or not to have CPR. It's written quite clearly in a number of places. In the name of the B'Shem and Olbach, if it's just going to extend their life or momentarily and cause them lots and lots of pain. But again, he's talking about end-stage illness, he's talking about people where there is no chance of recovery. Regarding advanced directives, the problem is if you sign them when it's too advanced, you just don't know what's going to happen in a situation where we know what the diagnosis is, we know what the prognosis is, we know what CPR is going to, what the chances it's going to work, and the pain the person's going to be, excuse me, and the chances that they're going to survive are going to be so small. So there are situations that would be mandated. However, when it's done too much in advance, then how are you going to know? There are too many scenarios, there are too many cases, and sometimes you've tied the doctor's hands from helping you when they could be helped. So I think in such a situation, what should be done, if people want to do direct advanced directives, is in a way where they can discuss it with the family, with the doctor, with their rabbi, and say, if I would be in such a situation, then I wouldn't, because sometimes it cannot be done in a timely fashion, but maybe they can discuss potential situations which would be in the future, which we do not know at the moment. And in most situations, they can decide, if this happens, then it would be A. If that happens, then it would be B. I think that would be a better way, halachically, to do it. And this definitely would be in the case of the United Kingdom, because many times in any case, the clinical staff, they will make the final decision for the person, whether you wanted it or not. So I definitely think in the United Kingdom, it will definitely be different to other countries as well. And if that's what the clinical decision made by the doctors and second opinion, and there's nothing you can do, at least, you didn't make that decision at the end of the day. The last thing, and Dr. de Wolff did speak about this, but there is a study, which I did actually share with him as well, where it talks about there could be, and this is wrong, and all doctors acknowledge that as well, but at the end of the day, this factor by signing the DNR status, and he writes that to do not resuscitate status could also be causally responsible for increased mortality in patients with DNR status as well. So this is a very interesting study, which I definitely think people, and even subconsciously, that could have an effect, unfortunately. And I wrote to a doctor. A doctor actually asked me, can you please send me this paper? And he wrote to me at the end, I'm not going to mention his name, we see this in practice sadly all the time. It's current and relevant. So unfortunately, that might be something which needs to be taken into consideration as well. And I suppose this is the most important slide of the whole talk, and I'll finish with this. What is the algorithm, to make sense of everything which we've said? And the answer is, there isn't one. We cannot, just work out how in this situation, in that situation, and come up with some sort of computer code. This has to be decided together with the doctors, together with the patient. And this is also a word of caution for rabbis as well. Sometimes when somebody phones you and will tell you, listen, this is the situation with my relative, this is what the doctors say. It's very difficult for them to pass on all the accurate information. And this is where we will need the doctors with the families and the rabbis who are asked to work together and on a case-by-case analysis, and, come to a decision. There would be times that it would be permitted, there would be times it wouldn't be permitted, there would be times where we would say maybe CPR wouldn't be necessary, but certain types of medical treatment should. And again, the question of the oxygen, the question of the hydration and the nutrition. I will leave it here. If there are any questions, I will try and answer, but I think this is a general guide. There are gray areas, there are exceptions to the rules, but I think as an introduction to the subject, that is quite clear of all the different main halachic responses. And like I said, not everything written is authoritative, unfortunately. And sometimes rabbis, even great rabbis, wrote things where many years ago and subsequently they retracted, and it is very important to be up to date with all the halachic analysis. Thank you very much.
Thank you very much, Rabbi Finchas. That was a very illuminating talk, and I think really helped a lot of us understand the halachic issues involved. I know you're obviously 2 hours ahead of us and it is very late for you, so we'll try and keep the questions brief. I think if we asked every question and allowed you to answer it fully, we'd probably be here till sometime next week. But I think the questions probably fall into a few main categories, so maybe I'll try and just ask briefly some of those categories. One question came up was when you were discussing the circumstances in which a Chai can decide not to have treatment, you mentioned pain as a symptom, and a question came up about, is pain the only symptom? Or we in palliative care, we talk about people who are either breathless or who have severe nausea or who are very agitated. Is it only pain, or is it any intractable symptom?
So again, we have to weigh this up, but my main point was this just wasn't a blanket leniency. We don't have to treat. The rationale behind that, and like I said, the 2 sources which Feinstein actually quoted were based on pain, whether it was the pain which Rebbe had or he felt. He actually translated and understood the Shulchan Aruch, where you cannot stop a neshama who's trying to part from a body and prolong the life in such a situation that you were causing pain, where even we don't necessarily see that pain. So there definitely has to be a certain, again, if pain can be controlled, then maybe it won't apply. If the pain is not controllable and he's suffering, and there are certain situations where with Shlomo Zalman, for example, speaks even with psychological suffering. So it's not just, I think it is an excellent question. It's not just a question just of pain, but there could be other issues, but it's not, on the other hand, just, okay, it's Chayesha, he's got, and especially if we're talking about Chayesha up to 12 months, that's going to be really difficult to evaluate. Prognostics, doctors tell me, is one of the most difficult things which they find challenging. We don't know. So with an end case chronic illness, we know much easier, but we see the body shutting down. We know much more, have much more experience. But let's say with acute illnesses or the case where you were talking about with frailty, it's going to be much more complicated. So we do have to weigh it up. But I won't be able to give direct, guidance now, because like I said, we do need to hear the case, like you brought on the screen, the 3 cases, hear what the doctor says, hear what the patient says, what are the options, what can be done, what can't be done, what are they suffering from, and then evaluate the situation.
Okay, so a quick question then on, again, that definition of Chayesha and the prognosis, and not so much necessarily exactly what the time frame should be, but how do we define what our medical prognosis is? We know we can give ballpark figures normally. We can often say we know that at 3 months, 50% of people like this will be dead. Are we looking at ROV? Do we just need to say 50.1% of people are going to be dead to define that as Chayesha? Are we, we're in the halachic framework of deciding majorities? Are we going to have to come down to decide what defines this person's prognosis to allow us to say they're Chayesha or not?
So again, that's another very important question which you're asking. We would have to, like you said, in medicine, very often it would work statistically with the end stage, illnesses. It's going to be much, much easier. If the vast majority, I wouldn't say a 51%. Again, Chayesha, some people talk of up to 6 months. That's what the Acute speaks about. With Moshe Feinstein, does take it a bit longer to 12 months. The longer it is, then I would be more cautious, but I would see and look at the pain factor as well. So you'll have to weigh it up together. If they are in considerable pain and it's not treatable, then the longer the Chayesha is, even if it's statistically, maybe there is more room to be more lenient. But if, for example, there isn't really a pain factor, and the Chayesha could be a year or 2, even longer, statistically, then that would mean that would be a less chance of having to do, there'll be more of a chance that you still need to do treatment. There could be a difference between more aggressive treatments and less aggressive treatments as well. So we would have to look at the combination of factors here and all the different variables and the treatment options and then make a decision. But, to give a specific answer to such a question where there's so many variables involved, it's going to be really complex. And like I said, at the end of the day, we do take what the patient, feels and his wishes into consideration.
Okay, and then there were a number of questions about what we as healthcare professionals working within the UK, in the NHS under those GMC guidelines, how do we marry up our practice that's expected of us and the halacha? So a range of things from, first of all, for my patient who refused treatment, although she wasn't dying by any stretch of the imagination. If I were to have given her antibiotics or anything at that stage, I would have been guilty of assault under UK law. And I would could have gone to prison, certainly would almost have been taken to the GMC and potentially struck off. So am I halachically obligated to do that? Going on to the possibly another extreme is thinking about even in patients who maybe there is halachic grounds to not treat, but they want treatment. we work in it or we think shouldn't have treatment, but or at least our employers think there shouldn't be treatment. And part of our job is to screen people and to think about who would be appropriate for treatments that are very costly to the system, and both in terms of money, but also in terms of people working, and so taking away people from treating other patients. So there are going to be harms to the system by us making people for intensive care admissions and saying people should be resuscitated, and when those things happen, do we have to say, well, the halacha is that they should be for this, or do we have to say, actually, it's my job, my employers expect me to do it this way, and I have to do it this way?
So again, two excellent questions. So the first question, the answer would be that if somebody has signed or just said, I do not want you to treat me, at the end of the day, your hands are tied. What can you do? You know, whether legally you can't do, you'll be charged of assault, and also practically, there's not a way where you can actually forcibly, you know, treat them. Sometimes you need a team, sometimes you need to, like, you know, actually hold them down to treat them. So your hands are tied, so you don't have any responsibility in that situation. There is a difference actually between the Feinstein and the Boudenberg. The Boudenberg would say that if your hands are tied, there's nothing much you can do, then you're not expected to do more about risk your job because of that. At the end of the day, your hands were tied. The Moshe Feinstein says actually something different. He says, no, you should try and do anything that you can within your power in order to help. But that, again, isn't something which is going to be practical, unfortunately. Regarding the second question, what I think, especially in the United Kingdom, and this is what I recommend for doctors to say, is listen, you have to understand, this is how the system works. This is what treatments are offered to you. This is my role. And, you know, just be as honest as possible. You're saying, in your situation, if it was somebody else in your situation, doesn't make a difference. My recommendation would be, according to GMC protocol, is that you wouldn't need to have DNR. But like it does say in the protocol, that you would be, you know, you can offer them a second opinion and they can take legal action. But at the end of the day, my role as a doctor is this, and this is how much I'm able to do, and from what I know is done. Now, I do know there are many situations where things can be accommodated, especially in gray areas, and I think that something should be, you know, encouraged. And you can say, listen, maybe speak to the supervisors, maybe speak to the hospital policymakers, whoever there is to, you know, who make the decisions, and something can be worked out. But I just feel that a doctor needs to give the accurate information, saying this is my medical opinion, this is the legal opinion. You can take this, speak to the rabbi, and decide. These are, if you do not accept this, these are your legal options, but otherwise there's nothing else which can be done. I just think that would be the best way for a doctor to, you know, to go ahead.
That's excellent. Thank you very much. Really helpful and clear answer there. I think it's getting late even here, never mind for you in Israel, and I think we should probably wrap things up here. I'm just going to say a few thank yous. Thank you, first of all, to Rabbi Finchas, who has given a really comprehensive, thorough talk and given us some very clear advice. Thank you to Dr. Yaakov de Wolff for, again, very, very clear talk explaining to the non-medical experts exactly what CPR is, and thank you to Dr. Alicia Kahan for his setting up this group. I know there were lots more questions, but we don't have time now. Thankfully, there are many more events planned where we'll be able to discuss with a range of doctors, a range of rabbis, different situations, start of life, end of life, middle of life, you name it, there will be events on those things. And we hope that we'll see you all again soon, and we hope that Rabbi Finchas will join us again at some stage in the not too distant future as well. Thank you, everyone.
Thank you.
Thank you very much.
Thank you.